I'm making it live on YouTube, ma'am.
Okay,
Once
okay.
I start, I'll hand over to you, ma'am.
Yes, yes. Yeah, you share the presentation screen. Yeah.
Ma'am, we are live on YouTube. I'm starting the recording. Dr. Mans, can you share the screen? First of all, this is Ranjit Sahu. Welcome you all. I'm marketing head with Waterbusa. Welcome to AMOX Public Awareness Committee PCOS Awareness Webinar. We have esteemed delegates all across the country. We have joined for this webinar. With this, I hand over the session to Baldava ma'am. She is a gold medalist of Fellow of American College of Obs and Gynae. She is an Obs and Gynae fertility consultant, SS Baldava Hospital, Solapur. She is a treasurer, SOGS 2017-18, Honorable Secretary, SOGS 18-19, and executive member of SOGS 21-23. And she has presented international paper on successful fetal outcome of 95 COVID positive pregnant patient in Jan 22. So with this, I hand over the session to Pratibha ma'am to take it forward. Over to you, Pratibha ma'am.
Thank you so much. I am at the outset very, very thankful to the PAC committee of the AMOGS. They have been conducting various webinars to raise public awareness about various important topics. One such topic is PCOS. As we know, infertility is on a rise, and so is the incidence of PCOS. Obesity is increasing, and which in turn also increases the incidence of PCOS. Polycystic ovarian syndrome, as we know, is hyperandrogenic anovulation and is increasingly seen in young women these days. So let us go ahead straight to the webinar and increase our awareness and insight into it. May I welcome for this Dr. Monica Umbardand, who is the chairperson of the Public Awareness Committee of AMOGS. Monica Umbardand is a very close friend of mine. Okay, she's a very close friend of mine and a director of Atharva Fertility and Mangala Nursing Home. She is the public awareness chairperson for this year, a website coordinator for MOX 1820, Shulapur OBGY Treasurer. Okay, no problem. Please take ahead. Yeah, please go ahead.
Yeah.
Okay.
At the first outset, I would like to thank Pardeshi sir and Sujata madam for allowing us to conduct this webinar under the AMOX banner. As we all know, September is the PCOS awareness month, and more patients in our OPD are coming with obesity, polycystic ovaries, and in turn infertility, whether primary or secondary. Also, we have seen its long-term sequelae, including the metabolic syndrome, diabetes, and hypertension. So we thought it would be much important to make our doctors at least aware about the lifestyle modifications and its impact on PCOS and the entire spectrum of PCOS, which Sneha madam will be moderating. I also would like to thank Kiran sir and Amay sir for accepting our invitation to be the guest of honor, and Dr. Pratik Kamble sir, who has agreed to be the faculty for the same. Thank you everyone for joining in. Over to you, Pratibha, for introduction of Pardeshi sir.
Yeah. I would call upon the chief guest for today, Dr. Rajan Singh Pardesi sir, whether you want to say a few words. Dr. Pardesi sir is the current president.
Pratibha, it's okay.
Yes, sir. Please go ahead.
Good afternoon, everybody. Respected Dr. Kiran Kurtakoti, Dr. Amay Purandare, Vice President AMOGS, Dr. Sujata.
Please stop sharing the screen.
And my Monica and Dr. Sneha with Dr. and Dr. President-elect Dr. Umbardand for organizing this webinar on PCOS. Monica is very active and actively doing work of this committee. Not every month, but I think average monthly 2-3 activities of Monica will be there for AMOGS. with the galaxy of speakers, chairpersons, and panelists. I think this will be a great event. I wish every success to Dr. Gorakh Mandrupkar, Dr. Sneha Boyar, Dr. Rashmi Kahar, Dr. Bharti Rajsekar for their future endeavor in FOCSE. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Over to Pratibha.
Thank you. Thank you so much, sir, for accepting our invitation and being there always for our committee and for being constant encouraging support for us. We thank you so much, sir. Pratibha, please introduce our guest of honor, Amey sir, please.
Yeah, can I have a slide, please? We welcome you, Dr. Amey Purandare, sir.
Thank you, Pratibha.
Yes, yes. I want CV of Dr. Amey,
The
sir.
next slide, please. Can you change the slide to the next slide, please?
Dr. Maj, please take a slide of Dr. Purandare, sir.
If there is a problem, I think we can go ahead, Monica.
Just give
So
us-
we would like to have a few words from you, sir. Amey, sir.
Sir, formally introducing Amey sir as my undergraduate as well as postgraduate teacher, sir. You have been the constant
Dr. Maj,
driving force
I will share. Wait.
for me too, sir. Thank you always for your encouraging words, sir. I would request you to please bless us with your.
Thank you, Monica, for inviting me for this very important webinar. I think, Monica, like Dr. Pardesi said, I second totally that she is really working very hard and making sure that the Public Awareness Committee, which Dr. Pardesi created and gave her the responsibility, is doing justice to its role and function. I think as doctors, we need to realize that till the public is not aware about the various health and disease issues, our job is not complete as a physician or a woman healthcare provider. The topic today that he has chosen is PCOD, which is apt because the PCOD month is coming up. And that's why we need to keep in mind that this is the modern pandemic or the modern lifestyle illness that we are encountering in our patients with wide spectrum, right from cosmetic issues, infertility issues, pregnancy complications, and even perimenopausal and postmenopausal serious health risks. So I think if we make the public aware through such webinars about the lifestyle risks and how we can troubleshoot them, it will be doing a great good, because always prevention is better than cure. Once again, I compliment Monica for excellent organization and wish her the best with such eminent faculty and great speakers. I think that it will be one of the kind webinar this evening. Thank you.
Thank you so much, sir, for always being there and for the constant encouragement. I request Pratibha to now move forward with the academic session. Even Gorakh sir has joined now. Pratibha, you are not audible. Unmute, please.
Thank you so much, Amey Purandare, sir, for those kind words and words of wisdom. The chairpersons for today are Dr. Gorakh Mandrupkar, sir, and Dr. Rashmi Kahar, madam. Can I have Dr. Gorakh sir's CV, please? Dr. Gorakh Mandrupkar, sir, is a consultant and a director of Angel IVF Pune. He is a postgraduate in clinical research and medical legal system. He is a vice president Justices Indian Association and a mentor task for national policy on PPH, Government of India. He has invented the Justices score and is very means instrumental in decreasing the risk for eclampsia, zero pre-eclampsia by 2024 is his aim. And he has drafted guidelines on hypertension and pregnancy and written 4 books. I welcome you, Gorakh sir. Our other chairperson for today is Dr. Rashmi Kahar, madam. Dr. Rashmi Kahar, madam, is chairperson of AMOG's High Risk Pregnancy Committee, organizing secretary AMOG's 2020, secretary Amravati OBGY Society. She has she has 3 gold medals to her credit, and she has won many awards. I welcome you, Rashmi Madam. Put to the chairpersons to conduct the first session.
Right, so shall we start? Hello.
Good afternoon, sir.
Hello.
I think we can hear you, Gaurav, but I think.
Right. Good evening, all of you.
Yes, sir. You can start. You and Rashmi Madam can start the first session, sir.
Okay. Right. So good evening, all of you. And we are very much thankful to be here in the presence of our President own, Dr. Pardeshi sir, Dr. Hello. Host has muted me. Sachin, should I?
So you're audible now. You are audible now, sir.
So I'm very much thankful here, and I think this is very important session today, because as Dr. Purandare sir has rightly said, we should see towards this polycystic ovary syndrome in a different manner. And it is not only that the person has come to us and we are doing prescribing only OC pills, the days have gone, or just lifestyle modification only, etc. So all these things now they have gone, and really a syndromic approach towards the polycystic ovary syndrome has to be done properly. And I think from this point of view, this webinar will definitely throw a light. So thank you very much for choosing this topic. And the speaker is apt one. So now may I request Dr. Rashmi Kahar Madam to introduce today's speaker, esteemed speaker, and to go ahead.
Thank you so much, Gaurav sir. Pratibha Madam, if you can put Pratik sir's CV, please.
The next slide.
Yes. Sir, CV here.
It's my great honor to introduce a great academician, Dr. Pratik Tambe sir, to this house today. Sir is ART consultant and gynae endoscopy surgeon, Ashirwad IVF Center, Mumbai, and is an international he has international diploma in advanced laparoscopic surgery, and is trained in assisted reproduction from Belgium. He is trained in clinical embryology and ICSIAT London in Singapore. At present, he is chairperson of AMOG's Endocrinology Committee and governing council member of ICOG. He is patron and managing council member of MOGS and managing committee member of Indian Society of Assisted Reproduction. He is also managing committee member of Maharashtra chapter of ISAR and has been past chairperson of FOXY Endocrinology Committee 2017-19. But he is a recipient of 30 MOGS, MOGS, ISAR, and FOXY prizes and awards. And to his credit are more than 24 books as an editor for FOXY focuses and handbooks and 11 key practice points. But more than that, we know him as a true and a great academician of Maharashtra, not only Maharashtra, but all over the country. And it's a great honor on our part to welcome you, sir, for you to this talk.
And
Thank you, everybody, for
Dr. Pratik Tambe, sir.
yes. So till Dr. Pratik Tambe starts the slides, yes, really I want to add one thing, that he has his own great data on polycystic ovary syndrome. And that's why, sir, we would like you to hear on the concepts with which you are going ahead. Over to you, sir.
all right. Can you see my slides, please?
Yes, sir.
Okay, I think there is some connection issue. So I'm going to keep my video off and I will proceed to speak. So let me begin by thanking Dr. Monica Umberden and Amogs for this opportunity. It's always a pleasure and a privilege to be here in the company of distinguished stalwarts, our esteemed President, Dr. Rajendra Singh Pardeshi, our two Vice Presidents, Dr. Kiran Kurtakoti and Dr. Amay Purandare, Dr. Sneha Bhoyar, Dr. Gorakh Mandrupkar. Thank you so much for being here. I am here to talk about a very boring topic, and that's lifestyle management and its impact on PCOS. And I'll try and make it as interesting as possible over the next 20 to 25 minutes. A man is worked upon by what he works on. He may carve out his circumstances, but his circumstances will also carve him out as well. So said the American reformer Frederick Douglass. And I think that is apt because in PCOS, whatever treatment you give, whatever interventions you prescribe, they impact the course of the disease. They work on you at the same time as the disease impacts you and works on you and your patients. Let's start by asking the obvious question. There is so much of attention that is focused on PCOS world over, including in India as well. Is it something which is being overdone? Are we overdiagnosing PCOS? Is it a real problem? Are the pharma companies simply amplifying PCOS because they want to sell their products to us and they want us to prescribe their products to our patients? Let's look at the evidence as it stands and answer this question. For this, we turn to this beautiful study, which is the largest published data of 194 countries. And this is the global burden of disease of PCOS, which is published in Human Reproduction Update in 2021. Though the data is from 2017, it was slightly delayed as far as publication is concerned because of the pandemic. And here they reported that in 2017, about 1.5 million new cases of PCOS were reported globally. Obviously, the real numbers are significantly higher because PCOS is not a notifiable disease like malaria, typhoid, and dengue. But we have to work with whatever data is available to us and what is published data. This is an increase of about 4.5% over just 10 years from 2007 to 2017. And the global age standardized incidence is about 82 per 100,000 women, which again represents an increase of 1.5% over the past 10 years. It's much more interesting to look at graphs. And if you see, countries like Sub-Saharan Africa are represented by yellow. And these countries have shown huge peaks as far as incidence and prevalence of PCOS is concerned when you look at 10 years of data. In contrast, in India, there is a rise as well, but it's a much smaller rise as compared to these countries which you see, which are represented in yellow. I have no doubt that with increasing westernization of our culture, the mall and the fast food culture, which is now very much prevalent amongst our youngsters, we will not be very far behind in hitting these yellow peaks if you look at data from 2017 to 2027, as and when that gets published. Yes, it is definitely a concern in modern India, and we have data which shows that about 1 in 3, that is about 36% of all adolescent girls now are being recognized to have PCOS in India. And we have youngsters who are even before they exit their school and colleges who are being diagnosed with metabolic syndrome. This is the silent epidemic of our times. What does the evidence say regarding management approaches, which is the topic of the day? For this, we turn to the published guidelines. This is the old ESHRE guideline, which was published in 2018. We have the newer guideline, which has just been published last month in August of 2023. And this is freely available on the internet, both on the ESHRE as well as the ASRM website. In case you can't find it, please feel free to write to me. I'll be happy to share a copy with you by email. If the 200 plus page guideline is very boring, laborious, and tedious to read, they've summarized the best and the most important recommendations from the guideline. The same authors, Helena T. et al., have published this in the European Journal of Endocrinology, which is again published on 15th of August 2023. Again, this is freely available. If you can't find it, write to me. I will share it with you. We know that the clinical presentation can be myriad. It can be multiple different combinations of acne, hirsutism, irregular cycles, obesity, and mental health issues, which are more and more a concern, especially in youngsters these days. But far more important for us is to realize that PCOS, as described in our textbooks and all the guidelines in the world, is the Western or Caucasian concept of PCOS, whereas PCOS in India is a different animal altogether. It's a different subspecies, so to speak. In fact, it has been diagnosed that in South Asian East Indians or South Asian PCOS, to be very specific, it is diagnosed as irregular cycles, obesity, and incidence of AN as compared to same Caucasians. And of course, we know that in Indians, we are sarcopenic, so there is a lower BMI, but there is a higher amount of central body fat. What does this translate to? Over a period of time, you will find that these patients have early onset metabolic syndrome, which I just referred to a couple of slides ago. They are unable to lose weight, and if they do manage to lose weight, they are unable to keep that weight off over a period of time, over 2 to 3 years. Despite their best efforts, they regain whatever weight is lost. There is clomiphene resistance, and in some patients, there may even be gonadotropin resistance. This goes hand in hand with lower fertility. And what we are now discovering is that these patients also have poor endometrial receptivity with a higher incidence of others equally, which we'll come to in just a couple of minutes. This is the PCOS plate that you see on the right, which has been proposed for women who suffer with PCOS. Half of your plate should be completely low starch vegetables. One quarter has to be dense protein, and that has to be high quality protein. And one quarter of your plate should be topped up with healthy fat. And this is the ideal PCOS plate. It's very easy to say that this is what is the diet to be followed. We'll see what are the practical issues and hurdles, challenges to implementation in just a couple of slides. We'll come to that. But more importantly, before we go there, we need to understand why we are shouting from the rooftops about BMI, weight gain, obesity, and infertility. Because there is a logarithmic or a geometric proportion as far as BMI and fertility is concerned. This is one of my favorite slides. I have been showing this in almost every presentation on PCOS for the past 20 years. And this is data from 1994, and this is a very relevant slide to today's discussion. What this particular paper from Rich and Edwards tries to show is that with just 1 point increase in your BMI, the chances of infertility go up astronomically, what we call in mathematics as logarithmic or geometric progression. For just a 1 or 1.52 increase in BMI, your chances of being infertile increase exponentially by order of almost 30%. So 28 to 29 BMI is not a big difference as far as points on the weighing scale are concerned, but the impact that it has on fertility is far reaching and very difficult to explain to the patient unless you have a graph like this in front of you. Furthermore, it is well known that patients who are overweight and obese and who are anovulatory can improve their natural interior milieu and ovarian folliculogenesis simply by incorporating easy and to the point lifestyle change. This is a very old paper again from 2003, but they said that to kickstart fertility in these patients, you need only 5% weight loss. And this 5% weight loss over a 6-month period, they found that patients had 80% regularization of menses, 60% of these women had ovulatory cycles, 40% became pregnant on their own. And this is published data. This is not something which I have generated on my own. There is a reference for this, and you can look it up. And it is found that these women were able to conceive on their own without any further fertility treatment required, not even timed intercourse, planned relations, not even IUI. So this obviously means that if this is implemented and patients are able to maintain this weight loss over a 6-month period, probably they will not need all that much advanced infertility. The difficult part is how do you get your patient to lose that 5%? Another paper which I'm very fond of is this is from Professor Robert Norman from India, and he talks about this is again an old paper from BMJ. BMJ typically will not publish OBGYN papers, but if they accept it and they publish it, they will publish it in OBGYN papers. And this paper is titled Modification
Some problem with the network.
Yes, I'm having problem with the network, unfortunately, at the clinic for some reason. So I'm going to reshare and I'm going to resume. Just let me know which slide I should go to. Can we go to the next slide?
Not able to hear you, sir.
Yeah, so I'll start from here.
So we can see the slide, but your voice is not audible.
That's because somebody else is speaking. I'm waiting for them to
Somebody
stop
else's
speaking.
voice is audible, sir.
Yes, I'm waiting for them to stop speaking so that then I can start. Okay. So as far as the impact on ART outcome is concerned, Professor Rob Norman and his colleagues have shown way back 20 years ago that if your BMI is between 30 to 35, the outcomes are reduced by 30%, irrespective of how good your take-home baby rates are in your particular center. You might be the best doctor in the world, but still, you will not be able to cross this hurdle. And in fact, if the BMI is more than 35, then the outcomes are reduced by 50%. As I was saying, remember that these BMI figures are for Western civilization. For Indian patients, these BMI figures are to be amended by at least 5 points. So 30 to 35 becomes 25 to 30, and more than 35 becomes more than 30. And if we look at ourselves in the mirror, I'm pretty sure most of us have a BMI of more than 30, considering our age, our lifestyle choices, and the way we eat and drink, and we have stresses in our practice. There's a beautiful paper which was published in 2006, and this specifically looks at BMI and ART outcomes for women aged 35 to 45. Or OR decreases by 0.84. And if your BMI reduces by 1, then the chance that your patient will get pregnant increases by approximately 20%. That's the 1.19. The translation into simple English in case you are counseling your patients. So let's go to the management principles. What specifically do the guidelines say, and what is the key practice points as far as management of the weight and lifestyle is concerned? The most important tenet here is that there has to be a multidisciplinary team approach. All of us, as I was just alluding to, we need to lead by example. If we are fat slobs, overweight, never moving from our chairs, with a weight of 100 kilos ourselves, no patient is ever going to listen to us preaching from the rooftops that, okay, you need to lose weight, you need to do this, you need to do that, etc. So we need to lead by example. Always take an endocrinologist, nutritionist, and a dietitian somewhere into your team, even if they're not under the same roof. Then you need to involve them in the patient's care because this is long-term therapy. A personal trainer and a good sports medicine person is always welcome, but not all of us may have access to such a person. And as I was saying always, you need to lead by example and you need to have periodic reinforcement. These two are the most important concepts on this slide. We will come to the issue of periodic reinforcement a little later, and we will discuss that in more detail. The NHLBI in the US has given certain obesity guidelines, and I found this to be very pertinent for our patients specifically. Before we tell our patients that they need to lose weight, it is important to evaluate whether the patient is actually ready and motivated to lose. If you motivate them and you ensure that they continually have that motivation with periodic reinforcement, you have won half the battle. And there are a number of potential barriers and challenges to the patient's adoption of this change. And that's all listed here in the slide. For reasons of time, I will go ahead and I will not read out the entire slide. Basic do's and don'ts, which we always advise our patients. No starving, no crash diet. Always have professional help, especially where diet and nutrition is concerned. Encourage physical activity. We'll come to the HT guidelines in just a couple of slides. The key here is to have timely eating to ensure that the right hormones, leptin and ghrelin, are catered to at the right times during the day, and patient has to have regular follow-up for counseling. The guideline recommendations regarding lifestyle management, these are from the HT guidelines from 2018. Have a caloric deficit of 500 to 750 kilocalories per day. It's very easy for them to write 1,200 to 1,500 kilocalories per day. If you or I were to consume only 1,500 kilocalories per day, we would be starving throughout the day. We would be hangry. I don't know how many of you are familiar with the concept of being hangry, and we would probably snap somebody's head off or bite somebody's head off if we had such low calories which we were consuming every day. But the fact remains that if you are able to reduce even 10 to 20% of your daily calories, it will make a lot of dividends. You will reap a lot of dividends in the long run. These are the modifications as per ASHA new guideline, which is now published in August of 2023. What they say is that you don't endorse any particular diet. You can choose whichever diet you want. The key is adherence.
Hello sir, तुमचा आवाज
Voices.
गेला.
His network is still again hang.
Yeah. No,
Pratik sir, are you there?
I
Madam,
think
त्यांचा network
there's
issue
some
दिसतो.
network issues, I think.
हा.
हाँ मी फोन करते मामी प्लीज.
Today, the network is particularly difficult and it's giving us too much thrust.
Now you're audible, sir. And
Yeah.
visible.
Yes.
Hello.
1 second. I'm just trying to share my screen again. So sometimes at the clinic, this happens. Apologies. It usually doesn't happen, but today is a particularly bad day. As I was saying, lifestyle modification, Eshre has plenty of recommendations. They are here on the screen for you. But I think the most important words on that entire slide are that we need to have a lifelong focus on prevention of further weight gain. If we can do that, if we can motivate our patients to do that, and if we tailor our therapy towards that, that will make a world of a difference to our women. These are the exercise goals which both NHLBI recommends, and these are part of a lot of sports associations recommendations as well. You start with simple basic exercise like walking. You can do treadmill, you can do gym, you can do cardio, whichever way you want it, but start small and gradually build up. You can work up to 60 to 80 minutes per day. Aim to expend at least 1000 to 2000 kilocalories per week. And now even Eshre recommends that if you can use a smartwatch and a companion app like this, it will give you lots of good data and feedback. The problem is that patients are with us for maybe 10 minutes once in 15 days or once a month if we are lucky. And during those 10 minutes, we bombard them with a lot of things. Half the things they are not going to remember, the other half which they do remember, they are not able to implement, and we cannot motivate them more than once or twice in a month. What is required is daily motivation. We know that smartphones are evil. They have a lot of bad apps which keep regularly giving us dopamine hits and make us slaves to them. But there are good things as well, and there are good apps as well. If you have a good smartwatch with a companion app, this is my exercise data from the last year, 2022. The app actually tells you this week you're doing okay. Last week you were not doing so well. Oh, this month your number of steps are less. Last month you're doing better. What is wrong? You need to improve. This is feedback which you and I, as doctors and clinicians, cannot give our patients. It's easy for us to say, you need to have moderate intensity exercise, 120 minutes per week, at least 3 to 4 times a week for maintenance of weight loss. And if you want to lose weight, then you go up to 150 minutes per week. It's very easy for me to write it on. Practically, it's very difficult to enforce it, to achieve it, and to ensure that the patient keeps doing it week after week, month after month. That's where your smartwatches help. That's where the companion apps help. And that is again embodied by the new guideline. Can we control androgen axis, which is the basis of all PCOS, the basic pathophysiology in all PCOS? That's the next question we need to answer. Unfortunately, androgen excess leads to a lot of altered physiology throughout the body from head to toe. And try as we might, we cannot control it completely because there is an altered insulin sensitivity, there is a compensatory hyperinsulinemia, and there is an insulin resistance. This is our vicious cycle, which all of us are aware of, and where we need to somewhere break this cycle. We can break this cycle only by ensuring that there is good, excuse me, insulin resistance, which is broken. The way to do it is to either prescribe an insulin sensitizer or to encourage the patient to exercise. If you can do both, then that is the best thing because they will have synergistic effect. The best insulin sensitizer, I am tired of saying because I say it every time, is exercise. The best insulin sensitizer is not metformin, it is not myonisotol, it is not berberine. The best insulin sensitizer is exercise. Everything else comes afterwards. So whenever people ask this question, which is the best insulin sensitizer for my patient? I have given everything, but nothing seems to work. What will work is exercise, consistent, focused training with a personal trainer is what works. And the reason for that is carrying more weight and obesity has long-term implications. They are listed here on this slide. All of us are aware of these, but we don't convey that to our patients. Obstructive sleep apnea, pre-diabetes, gestational diabetes, hyperglycemia in pregnancy, atherogenesis, hypotension, impaired renal function, fatty liver disease. All of these are known to us. But when we talk to our patients, we rarely talk about the long-term complications that happen with androgen excess and abdominal adiposity. Also, we need to be aware that the older generation, metformin, works on the insulin receptor, which is at the plasma membrane. Whereas the newer insulin sensitizers, which are actually nutraceuticals, work intracellularly at the level of something called as PIP kinase. What are the tools for long-term success? And here we come back to behavior modification strategies, good counseling, and the services of a skilled counselor. There are a lot of things which are at play, which are beyond the scope of today's discussion. But these are well known to be the major challenges and the hurdles to implementation of lifestyle modification, including your self-esteem counseling, your body image perception, stress management, and ultimately social support. If you surround yourself with people who are 100 kilos, you're going to feel that being 100 kilos is absolutely normal. There is nothing wrong with you. But if you surround yourself with people who are all working out, exercising, 50 kilos, lean, fit, healthy, then you will feel that, yes, I need to be like that. Another important tool that we have, and which is now being discovered more and more to be of great benefit, is something called as self monitoring and journaling. You just observe what you are eating, you document it every time, you put it down on paper in a diary specifically kept for the purpose. You can also do it with smartphone apps which are available. But what I feel is the very act that you pick up a pen, write it on paper, and then you see how the progression is over a period of time adds a wealth of feedback to the patient, which she herself can see over a period of time without much intervention. As far as key practice points and protocols are concerned, all of you have seen these slides. We did these pioneering PCOS protocols of practice when I was Foxy chairperson, developed multiple different things, including this checklist. We also did a 7-step counseling guide in association with the International Aware Group. There is some new evidence regarding insulin sensitizers, and ESHRE also now says that inositols can be prescribed. Earlier edition, people used to say that these are something which are experimental, but that's not the case anymore. We've also developed new guidelines on acanthosis nigricans. These are being published very soon. We have some treatment options for morbid obesity, both surgical as well as non-surgical. These will be tackled in the Indian National Guidelines for Obesity, which are coming through ISAR very shortly. So to conclude, ladies and gentlemen, PCOS is the hidden pandemic. You have multiple different presenting complaints. The central tenet, the central problem is insulin resistance, compensatory hyperinsulinemia, and androgen excess, all of which can be tackled with insulin sensitizer. The best insulin sensitizer is exercise. Drug treatment comes afterwards. Lifestyle is key. Insulin sensitizers are the key. Once we are convinced, we will be able to convince our patients and have good long-term follow. Usefulness is about how you live and not about when you were born. The key here, what I feel my talk needs to convey to all of us is that we must imbibe these principles. We must live by these principles. We ourselves should not be 100 kilo fat slobs. And that is when we'll be able to convince our patients that this is the best way forward. Thank you very much for a patient hearing. Apologies for the audio video issues. Today is a particularly bad day.
Great. And yes, so it was a really fantastic talk, and really what the ideas what you gave are really right. Okay, first we should be healthy and we should look healthy. Then only patients will get convinced. The second important message what we got is that we have to sit with the patient for a while. And not only that, but ideally with the mother of a patient as well. Because when we put the impact on the family as a whole regarding the obesity, probably that will give a good effect. The third important message what we got from your talk was, yes, though Western guidelines, they say that BMI more than 30 and 35 you are high. For Indians, we have to consider -5. And then I think if we start calculating by that formula, then our 90% of the patient population will fall into that category. And now that is a high time that we all should work towards it very seriously. So thank you very much for giving such a nice messages during your and really helpful, Dr. Rashmi Madam.
Thank you, sir. It was really very enlightening talk. And as Dr. Gorakh sir said correctly, if you see from the patient's perspective, sometimes I feel that receiving a diagnosis of PCOS on a patient's part, it itself leads to psychological distress. And then it gives a sense of reduced well-being to the patient, sometimes depression. So sometimes I wonder if this is a part of, and this again leads to resistance into the lifestyle modification. So sometimes I just ponder if it's a result of the receiving the diagnosis of PCOS or it's a part of the syndrome itself. I think that makes the management part of the PCOS more complicated. And you have summarized it very well. Thank you very much.
Thank you, Dr.
Thank you,
Rashmi, Dr. Gorakh, and thank you, Dr. Monica, for this opportunity. Apologies for the AV issue.
Thank you, Prateek sir. It was an exhaustive talk covering almost all the aspects that every clinician should advise all the patients. And it was definitely much required for all the gynecologists that it will streamline the advice that we give to our patients. Thank you, Gorakh sir and Rashmi ma'am, for sharing this session. I request Pratibha to please take over and start with the panel discussion, which will be moderated by Sneha madam, and the expert is none other than Rakhi ma'am.
Thank you so much, Monica. Today we have a panel on PCOS at all ages, PCOS spectrum at all ages. So for this, I invite the moderators for today, Dr. Sneha Bhuyar madam, who is very close to us, the current president of Yavatmal IMA Society. Can I have a CV, please? Dr. Sneha Bhuyar and Dr. Rakhi madam. Dr. Sneha Bhuyar madam.
The previous slide, please.
Yeah. Dr. Sneha Bhuyar madam is well known to everybody. She is currently the president of IMA Yavatmal. She has received International MS Signature Award for Phenomenal Leadership in 2020. She has received Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics, Dr. Durusha Award, Dr. Anandibai Doshi Award, and she has almost 30 plus national publications. She is a part and parcel of many of the orations and talks which are being held at national level. So I welcome you, madam, to moderate this panel discussion. Our another moderator for today is Dr. Rakhi Singh, madam. She is a chairperson of Endocrinology Committee, FOXY 2020-23. She is vice chairperson of UP State, ISAR, peer review for Journal of Obstetrics and Gynecological Society India, and ICOG Governing Council member. She has many awards, FOXY Durusha Datta Award, CS Dawn Award, and many more awards to her credit. I welcome you, Rakhi madam, and hand over the mic to the moderators to conduct the panel.
So a very good evening, all of you. At the outset, I would like to thank the organizers, especially Dr. Monica, Pratibha, and of course, AMOG's President Rajendra Singh Pardesi sir and the entire team. I just share my screen and welcome all my panelists first. Pratibha, are you going to introduce them in short, or I just call upon them? So Dr. Rakhi, who is the expert for this panel, has been already introduced. So I take this opportunity to introduce Dr. Bharati Rajsekhar, who is from Karnataka and a very vibrant personality working almost in all the fields. And at present, she has joined from Bangkok. She has been invited to discuss on cervical cancer there. And Dr. Nanda Magai, who is the past president of Solapur Gynae Society, Dr. Jaya Tulaskar from Amravati, Dr. Mangal Rathi, Dr. Manisha Vasade, who is the secretary from Chandrapur, and Dr. Riddhi Desai, our young brigade from Mumbai. Dr. Lalita, I think, has not been able to join because of some medical emergency. So we welcome all of you. And without much ado, we start with the panel discussion. So as everybody talking about, PCOS, it is a multifactorial disorder, right from genetic predisposition to environmental factors to social and economical changeover, demographic changeover of the society. Of course, the lifestyle, which is to be blamed majorly, and it is contributing to almost 6 to 20% of the population, involving not only the adolescents, but the entire spectrum of ages, that is the entire reproductive age group. No less, it is not much of a difference in the...
Dr. Sneha, can you make it as a slide share mode? It is not yet made.
Yeah, so it is not different in the rural as well as almost, it is not different in the rural and the urban population, but definitely the incidence is on rise. And as you have, all of you are aware about the diagnostic criteria, various diagnostic criteria, and you have also accepted the consensus and the Rotterdam's criteria. The diagnosis has been, on the rise. Definitely, as we have talked about, the genetic factors, the environmental factors, the changing lifestyle of the modern society, the academic load, and of course, the lack of physical activity, all these factors contribute to it. So let us discuss and come to some consensus. I'm sure we start with this very basic case, and we go to the first panelist, I think this is for Dr. Lalita, but anybody can take up this. This is open for discussion. We have this young girl. Yes, we have this young girl. All the panelists will discuss first, then we will have to conclude later. So we have this 13-year-old girl who reports with her mother to the gynae clinic. The mother is very apprehensive about irregular cycles of her daughter. She has had her menarche only 9 months back. The cycles are 4 to 5 days every 20 to 60 days. Her BMI is 24 and she's got mild acne on the face. There's no other significant history, but she got her ultrasound pelvis done on suggestion of her friends, and that is suggestive of multiple follicles. So she's worried about this diagnosis. What is your diagnosis, and how would you like to investigate and go ahead with the management?
Can I take this?
Yes, Dr. Mangal, please go ahead.
First of all, thanks Monica Madam and Amox for making me part of this webinar. The diagnosis of this case is, of course, polycystic ovarian syndrome. Investigation.
Is it so, Madam, and how do you thought of this? What are the criteria? How did you come to the diagnosis?
Please show me case again.
She has got irregular cycles. She's only 9 months post-menarche, and she's got only mild acne on her face.
And USG diagnosis on USG multiple follicles in both ovaries.
Yes, but are we supposed to go for ultrasonography? In fact, this was the last question for this, but I asked you first whether you should go for ultrasonography for such a young girl who is only 9 months post-menarche. I think we just
Madam, shall I
for discussion? Yes,
Madam, shall I take?
Yes.
Actually,
we can have all of your views here.
Less than
Yananda, please give your answers.
Less than 1 year irregular cycle is not a criteria for PCOS, and ultrasound is not indicated in these girls, as multiple follicles are known to be found in adolescent girls. We should only reassure both the mother and the child. Actually, ultrasound is not indicated, but they have done it's okay. Because multiple follicles are known to be found in this age group.
Correct.
Madam, can I
just ask? Yes. You can go ahead. Can somebody contribute? Dr. Riddhi? Yes.
Thank you so much, Madam.
How do you label the cycles as irregular, post-menarche? What is the duration since menarche, and how do you label it as irregular?
So, Madam, the case that you have described here is something that is so common that we see in OPD. All of these patients come to you with their anxious mothers who have self-diagnosed themselves as polycystic. They have told themselves that this is PCOD. Why? Because the ultrasound somebody has done and said this is PCO.
Yes.
But we as gynacs should be extremely cautious while giving such diagnosis to the patient. ASHRAE guidelines has given us a very clear-cut guidance as regards to how and what we should call as ovulatory dysfunction and how we describe irregular cycles.
So whether it fulfills the criteria for the diagnosis, that is
Exactly,
the
madam.
first question.
So she is young, and in adolescence, it is very difficult to diagnose them when they are so near to post-menarche. Now the guidelines say, in fact, adolescents who do not fit the correct criteria, 8 years post-menarche, they should be taken up for a diagnosis again and an evaluation to actually term them as PCOD.
Yes.
So usually irregular cycles, which are say more than 1 year to less than 3 years post-menarche, or say more than 3 years post-menarche, or say maybe more than 1 year post-menarche, which is more than 90 days for any cycle, is the criteria of irregular cycles as defined by the ASHRAE guidelines. So in this case, we will be little more cautious in labeling this patient as PCOS. She has a higher BMI, and also, so madam, I think we will be coming to this
I would like
discussion.
to interrupt you here. This girl is only 9 months post-menarche.
Correct,
so
madam.
Here, her cycles are irregular. How do you fit in this? Whether it is really irregular?
So, madam, we tell them first 1 to 2 years post-menarche, the HPO axis takes a while to set. And this is how you counsel the mother that, you know, it takes a little while for their cycles to get a little more regular. So hold on to the diagnosis of PCOS, and there is really nothing to be worried about. Say 2 years or 3 years post-menarche, we reevaluate, and most likely her cycles will get normal.
Yes. So during first year, of course, irregular cycles are absolutely normal part of puberty transition. 1 to 3 years, if it is, if it is shorter, that is less than 21 or more than 45. After 3 years, if it is less than 21 or more than 35, or maybe even 8 cycles per year, that is what. This is a normally accepted pattern. And if anything which is, away from all these criteria, then only we can label this as irregular cycles. Now, why the diagnosis of PCOS is difficult in adolescents? Dr. Revati, do we have Dr. Revati? Okay, so either Rithi, you can continue with this. Why the diagnosis is difficult in adolescents?
Madam, actually, Dr. Bharti has raised her hand. I think since a while, madam has been waiting.
Yeah, I think I could not see her. You can go ahead, Dr. Bharti. Please.
Yeah, thank you, Dr. Sneha.
And we have Dr. Manisha also here. Yeah.
Yeah, we need to counsel them. See, the diagnosis of PCOS is not to be taken up in the early menarchal age because there's as Riddhi rightly mentioned, there's the immaturity of the hypothalamo-pituitary ovarian axis, and most of the cycles are going to be anovulatory.
Yes. In addition to this, what are the other factors which overlap with the diagnosis of PCOS and adolescents?
The acne is a part of adolescence, like probably due to the effect of progesterone, and then their exercise protocol, they may have a little sort of hirsutism which may overlap, and then of course, and the lifestyle which is nowadays not very feasible. You see a little childhood obesity still remaining in these young adolescents. So these factors overlap the features of PCOS and very often are leading to misdiagnosis, where all the OBGYNs have to be very cautious about.
Correct. So, Dr. Manisha, I would ask you, what kind of what kind and severity of acne you would like to take it as signs of PCOS or hirsutism, I would say. Because as Dr. Bharti said, mild acne, irregular cycles are quite common. It's a part of this transition. So how would you differentiate it?
So mild acne is commonly seen in adolescents, as we all see. But if the acne is persistent and it is not responding to the topical kind of treatment, then we can say that it is like it's a PCOD type of acne. And apart from that, other cutaneous manifestations, if she's having if she's having severe or moderate to severe kind of then we can say that she is having PCOD.
Yes,
But
correct.
if
So
the
mild
mild,
type of comedonal acne are common,
yeah,
but if
that
she
that
has
is common in
moderate to
adolescent
severe,
people.
that is,
Yeah, if
more than
not
10 facial lesions or moderate to severe inflammatory type of
inflammatory, which
acne,
is
then
not
we take
which
this as
doesn't respond to the
hyperandrogenism. Yes.
yeah.
And of course, somebody has said already, more than 10 years post menarche, you should go for ultrasonography. What else you should go for, and how do you evaluate the girl for hirsutism?
She's having a mild kind of, if she's having a moderate and severe kind of hirsutism, then we can label her as a case of PCOD, and also other signs of insulin resistance if she's having, and of hyperandrogenism, then we can label that girl as a PCOD.
Yes, so just randomly you should not label her as PCOS, just having mild acne and little hairiness here and there, but you should use the objective scoring system for labeling this. You know, all of you know what is Ferman-Galway scoring.
Yeah.
So
Yeah.
modified
Citizen is
W
very
score, that is what is to be used for objective evidence. So basically, this case is not a case of PCOS. It is just a normal puberty transition, because now that she has come to your hospital, you have evaluated her and you have counseled her as well as her mother that she doesn't have PCOS, but it is just a normal transition and you need not worry. But because she has come to the hospital, you may just advise her regarding good, healthy diet, healthy lifestyle, how she should remain active, so that in future she doesn't develop PCOS. And of course, because we are a gynecologist, we, all of us, even the family physician for that matter, should recommend HPV vaccination for this girl. And we may just advise, you know, a routine checkup, pap smear and mammography or vaccination for the mother as well. So I think that is a comprehensive discussion for this case. And now we go ahead with the second case now. Now we have this little older girl, 17-year-old girl who is in 11th class. And now she presents to you with frequent cycles. Of course, she has this frequent cycle since last 6 months, and she has a change of environment and working for almost 14 to she has joined some coaching classes. Her flow of the menstrual flow that lasts for 5 days. Cycles are very frequent, as I said, 15 to 18 days, and now she's almost 5 years post-menarche. So whether she really has irregular cycles, and how do you diagnose this patient? How do you evaluate this girl? The investigations which here they are provided here is TSH is 4.2, and of course the other hormonal profile they have advised. So how do you go ahead with the management of this case? Now I think we can take up the next panelist, as Dr. Riddhi has already discussed one case. So do we have anybody else? Dr. Manisha and Dr. Bharati, I think you can take up Bharati. Yes.
Yeah, well, going through the history and the laboratory biochemical parameters of this girl, most of the parameters look normal. This 15 to 18 day cycle is a little more frequent, but however, she seems to have a normal flow, and I think her hemoglobin is not mentioned there, but must be normal. So probably the stress, the psychological stress that she is undergoing because of her age, and the college and the stress and the peer pressure, probably there may be some sort of a psychological element which is contributing to her mild hormonal imbalance. So I think a proper counseling of there is cognitive behavioral therapy, ask her to de-stress, do regular exercises, have a nutritious diet, and if she's not bleeding heavily, I think we can just leave her alone, because her BMI is a little on the higher side. Her BMI is 26, so I think we'll have to counsel her on that aspect.
Yes, Dr. Bharati, but you have not answered the first question. Do we label her as PCOS?
No,
how do
no.
you take her cycles as with the regular for her menarche age? Yes.
Her cycles are not regular. She has her cycles in 15 to 18 days, but it's less than 22 days. But however, she has no other markers of PCOS like we take for the criteria, the Rotterdam criteria or the
What is the diagnosis? This
That
is
is
what we label it as PCOS at risk.
Yes, at risk.
Yes.
Because he's showing features of menstrual irregularities with a little increased BMI.
And BMI also little on the higher
BMI is
side. So this is
increased.
PCOS at risk. So
Yeah.
yes. So how do you go ahead with the management of this girl?
The first thing is we will have to sit and counsel her and give her a little awareness about what is PCOS, why it occurs and what eventualities it could have, the metabolic risks that can be associated with PCOS. And then we will have to talk to her about the lifestyle management is the modality of management for this girl. So she will have to have a programmed exercise protocol. And as Dr. Pratik Tambe was telling us, we have to tell her about her diet, that she has to take high proteins, reduce her carbohydrates, reduce her calories, and try to bring down her weight by at least 10%. She should do that. So that will contribute in reducing the insulin resistance and prevent her in becoming a full-blown PCOS candidate.
Right. So because she has presented to you with menstrual irregularity, hyperandrogenism, we need to evaluate further. But at this point of time, again, we need not go for ultrasound. We can just keep a watch and keep her under observation with strict monitoring. And if this persists, then we can go ahead for ultrasound with the criteria of 8 years post-menarche. Dr. Manisha, do you want to throw some light on the lifestyle modification?
Yes, ma'am. The lifestyle modification for these kind of girls who are at risk for PCOS, we need to counsel her regarding her lifestyle, her eating habits, and her routine, what she should follow. Like she should what sir has already told about exercise and diet. So we need to tell her about the exercise, what she need to do, like running, cycling, whatever physical exercise that will reduce her weight somewhat, will help her to improve her quality of life, and that will prevent her from going at risk for PCOS. And again, regarding eating habits, what sir has already told about the quality of diet she should have, and the timing of diet, that also should be important, because these girls nowadays, we all see that they have at any time they eat and any time they sleep. So regular ideal lifestyle has to be followed, routine has to be followed, and so that will prevent such girls from progressing towards PCOS. So lifestyle modification is the main part in this case.
Okay, what kind of do we have Dr. Nanda Magai?
Yes, ma'am.
Nanda? Yes.
Yes, ma'am.
So what kind of exercise and how much daily workout she should go for?
Actually, weightlifting and gym exercise are recommended. Even walking can be done for 1 hour, but it should be fast. The walking should be brisk, like not slow. And I think, and she should
So,
at least she should aim for 5% of her weight loss.
Yes. So do we have Riddhi contributing to this? Yes, Dr. Riddhi?
Regarding the exercise part, madam?
What kind of exercise she should do and how much daily?
So high intensity.
We can start from the basics. We can start from the basics. That you should go for active physical lifestyle. Don't use your remotes. Go for everything. Don't use the lifts. Use the steps. Maybe you just get down or stop earlier and walk a little. You park your vehicle away from your entrance. Go and have a walk. Of course, daily, whatever brisk walk. This one, Dr. Nanda was talking about. It has to be a brisk walk. So at least 30 minutes per day of moderate exercise, and at least 5 days a week. So that comes to 150 minutes. That is what it is recommended, but you have to individualize and you have to advise them practically. So I think that is about exercise, but doing her routine work in addition to this should be continued. What is the special advantage of yoga, Dr. Bharati? Whether you would like to contribute to this?
Well, yes. Thanks, Dr. Sneha. Well, yoga, we know, is the union of the mind and the body. And there is a psychological element associated with the hormonal imbalance in PCOS. And of course, there is the body shaming and the image disorders and the peer pressure and all these things. So when they do yoga along with their aerobic exercises of 30 minutes, which has to be cardio as well as muscle training and in high intensity exercises, I think this somewhere does contribute to some amount of this psychological aspect of the hormonal imbalance being addressed when they do the yoga and the pranayama. And various studies have shown that they do help in modulating the hypothalamo-pituitary ovarian axis. And I think we as the our ancestors have brought in yoga, and I think we need to inculcate this yoga and pranayama in our not only PCOS, pregnancy, menopause, all the aspects of women's health. We have to advise yoga, and I do it in my regular practice.
Yes, perfect. So in addition to weight loss, it makes your body flexible, improves the flexibility. I am sure you all have heard that if the body is flexible, even the vessels are become, very flexible, and it improves your lipid metabolism as well. So not only the carbohydrate metabolism, but also the lipid metabolism. And the bottom line is any kind of exercise improves your insulin resistance. So that is all about yoga and exercise. Diet, I think Dr. Manisha, Dr. Mangal, can we have your opinion on diet? How many calories? Suppose she wants to lose her weight. How many calories she should consume? How do we calculate it? From your basic BMI, how do you calculate it?
She should need 1200 calories per day, and to reduce her weight for PCOS, she should reduce 400 to 500 calories per day to get actual result. And in diet, high protein diet.
So what I wanted to ask you is whether you decide the calorie cut down over her recommended allowance, that is one, and whether it will depend upon her level of activity.
Yes.
Okay, so yes, can we have Dr. Manisha adding to this?
Yes, ma'am. She should take low carbohydrate diet with low fat, and high protein diet should be added to her meals. No junk food is advised, and particularly sugar-free foods are to be taken, and which includes more of vegetables, sprouts, and more of vitamin-rich fruits are to be taken. And apart from that, her
food pyramid. Do you want to comment on this? Yes.
Yeah,
Dr. Bharati would be happy to talk about this, the food pyramid.
Yeah.
Yes.
Well, when we talk about diet to this young adolescent, I'm sure it's going to be a very tricky situation. So, but the moment, see, it's very easy for us to tell them that you just take sprouts, you don't take desserts, you don't take ice cream, but we need to understand the pressure this young child will be undergoing. So I think we need to give her, like as Dr. Pratik said, that we give them a chart, and then we give them this food pyramid where we explain to them and tell them that it is not that you cannot eat chocolates or you cannot eat, but we need to tell them that you have to reduce the intake and of course give up the junk food, because what are the consequences of that? And we can always tell her that increase your activity level, incorporate food with high glycemic, reduce the ones with high glycemic index, don't take direct sugars, don't take sodas, and tell her that once in a way she can have a cheat day where she can either have a burger or she can have some chocolate or an ice cream, because she is a very young girl. And if we just tell her, eat sprouts, eat vegetables, don't eat this, don't eat that, rather than doing that, I think we should tell her, give her some positive thing, give her a picture of the food chart and the triangle, and tell her that you can incorporate those things as far as it is not high glycemic index. For example, instead of sugar, she can take some honey or something like that. And tell her that she just needs to lose about 5 to 10% of her weight.
Yes.
And give her smart, attainable goals, small goals, and appreciate each time, even if she comes and she's just lost 200 grams or 300 grams, praise them, appreciate them, that goes a long way in achieving those goals and motivates them.
So counseling, and you have to guide them very positively. Of course, you have to encourage them, as Dr. Bharti has very rightly said. And I think health education and sharing the responsibility of what their problem is and how they can tackle, that should be the best way of counseling, I think, and that should be the positive way forward. So with this, we go ahead with the third case. And we have this same girl presenting 10 years later to you. She's 27 years now. And she's got a hectic job profile, 12 to 14 hours a day, and maybe the night sometime. So initially, just before marriage or so, maybe she reduced her weight, so her cycles were regular. Now again, back to pavilion, she gained her weight, her cycles are irregular. And now she comes to you with irregular cycles, 50 to 60 days, very heavy flow, and her BMI is also increased to 28. So she has developed all these features of hyperandrogenism. She has got this hairs on upper lip and chin, and she's conscious about her looks, and of course she's worried. So when you do her examination, hormonal profile, that comes normal. How do you manage this patient? What are the issues to be managed for her?
Both
Yes,
non-pharmacological and pharmacological strategies are crucial. In this case, hyperandrogenism, irregular cycles, and insulin resistance drive most of its long-term consequences. So we have to focus on three. As we have already discussed, appropriate diagnosis of PCOS. Yes, I'm audible.
Yes,
I'm audible.
Yes. Sachin, can you mute the rest of the... Yes. Can we mute the rest of the attendees, please? Yes.
Management of insulin resistance and obesity should be considered the first line of treatment of PCOS. As already discussed, exercise, then again diet, and menstrual irregularities have to be covered with first progesterone withdrawal bleeding, and again this is the first line. Progesterone withdrawal bleeding is the first line.
She is getting her menses. There is no question of getting her menses, so we don't have to give her progesterone for withdrawal. She's getting 50 to 60 every 50 to 60 days. So Dr. Jaya, welcome. I could see you just now. So we want to hear from you. How will you assess her for hirsutism? What hormone you will be evaluating, and how do you go ahead with the management?
And we have to assess her for androgenism, hyperandrogenism. We can do free insulin, DHEAs, free testosterone level. Then for hyperglycemia or insulin resistance that she has, we can go for glycosylated hemoglobin, and also we can go for free insulin levels. Then fasting sugar we can do. Then we can go for free androgen index, and she may be having hyperlipidemia. So for that also we can evaluate her.
Yes, but we don't have to take it for granted that she has PCOS only. Whenever the girl shows signs of hyperandrogenism, we have to rule out the other causes of hyperandrogenism. And because the androgen comes from ovary, adrenal glands, and other external factors, maybe even the fatty adipose tissue as well. So you have to think of all the conditions, and that is how you have to evaluate her. Maybe the serum androgens, total and free testosterone, DHEAs, and dihydrotestosterone, and the free androgen index. And along with that, 17-hydroxyprogesterone, ACTH levels, even the pre-cortisol and the dexamethasone suppression test, to know whether it is of adrenal origin. That is how you have to evaluate. Now, suppose this patient has got hirsutism. All of you agree to this? Okay. So how would you go ahead with the management of this patient? Can we have some opinion from Dr. Riddhi? Yes.
So, Madam, about this case, earlier when we had seen her, she was PCOS at risk. Now, either she has definitely, so after doing all the investigations, we do need to rule out PCOS or anything else. As long as she is PCOS and her androgens are normal, then to treat her irregular cycle. So there are two parts to this. One will be a hormonal and the other will be a local or a non-hormonal management for her hirsutism. So she has, say, androgens are normal, but she does have clinical hyperandrogenism. So for this, we would like to give her a OC pill. Probably a drospirenone containing would be my choice to also balance her irregular cycles. And for the local treatment, I will ask the patient to do whatever is comfortable for her. We do tell her that, see, lasers would be preferable later on in long term, but a pre-androgen treatment, anti-androgen treatment would actually make her lasers more effective later on. And if her androgens are high, then I would like to, along with balancing her with a COC, I would also like to add anything like a finasteride, so as to maintain or so as to benefit her for her later hair growth.
Correct. So first and foremost, you have to differentiate whether it is hyperandrogenism of ovarian origin or adrenal. So if it is ovarian origin, then you have to give for the ovarian androgen suppression, what we have been giving, COCs and high dose progesterones. If it is adrenal origin, then you have to go for dexamethasone, right? And of course, in addition to this, when you are aiming at weight loss and also you find that she's got excessive fatty tissue, the adipose, then you have to go for spironolactone, cyproterone acetate as well. So what is the role of metformin along with all this? What do you feel?
So metformin is excellent as a insulin sensitizer. And I think it is a time-tested medication that really works well for these women. They also, so it works with various ways. When we give metformin, I think the biggest apprehension is anybody will tell them, even the pharmacist will tell them, "Ye to diabetes ka dawai hai. Is it diabetes that you have? She's such a young girl, usko kaise diabetes ho sakta hai?" So first thing when you prescribe, you tell them that, look, it is actually to make sure that this insulin resistance goes down and your ovaries start working better towards your hormones. So that is one medication. And nowadays also we have the benefit of the inositols. For these young girls, where inositols are also working very well as an insulin sensitizer.
Yes. So now, first and foremost, weight reduction, optimizing her BMI. That is the best possible treatment you can have. So dietary modification and active physical exercise, the way we have discussed. If that leads to weight reduction, maybe 5 to 10% of weight reduction is all that is necessary or sufficient. If it doesn't, then you have to go for the medication. And then what are the advantages of this weight loss? It improves your insulin resistance. So that's the reason it reduces the insulin levels also. So the hyperinsulinemia, which in addition leads to increase in the hyperandrogenism or the manifestations of hyperandrogenism, that also comes less. Because you have this weight loss and decrease insulin resistance, you have increased levels of SHBG, that itself reduces the pre-androgen levels. So the clinical manifestations of hyperandrogenism are also less. That is how all these things help. So do we have Dr. Rakhi here? Dr. Rakhi Singh? No? So can somebody discuss about the medical management? Suppose yes, Rakhi, we can see you. Hi, Rakhi. So so can we have some comments from you if this lady who is having PCOS doesn't respond to the weight reduction, whatever way she's trying, diet modification and the exercise? Suppose if that doesn't lead to a reduction of weight by 5 to 10%, what would be the medication of choice and how do you decide that?
As rightly said by Riddhi also and the others all, we need to start on metformin, and counseling of metformin is one thing which would help her at a greater length. Adding on a little amount of insulin resistance drugs like inositols or metformin does wonders, even though the weight reduction may not be there immediately. To a certain extent, it helps to boost the patient up, because these patients are definitely tired of doing vigorous exercise and reducing the weight, And we as a physician, we keep on telling them, you reduce weight, it is really difficult for them to reduce. But we need to counsel them also, in the other hand, telling that little amount of weight loss also, just a 5 to 10% would do wonders for them. So apart from that, if we are putting them up on, if we are not intending for a pregnancy, if there is OC pills which we have to prescribe, we need to understand which type of OC pills have to be prescribed to which type of patients. Though none of the OC pills have one over the other benefit to a greater extent. But when we talk about which to whom, it would be like, if it is a milder to moderate form of a PCOS, we can prescribe any of them. But if the patient is having hyperandrogenism type of symptoms, that is hirsutism is more in those patients. In that patients, we can put the patient on cyproterone acetate, which is the anti-androgenic type of it. That would do wonders for them. But whereas in the other hyperandrogenic patients where acne is more, we need to put them up on drospirenone type of pills. And we can always add on the other modalities of anti-androgens like spironolactone, all the others for add-ons for these patients, because these patients definitely would have certain amount of depression, and they have their body image issues to a greater extent. And we should always tell them, if there are hirsutism and acne is a grade 3, grade 4 of it, then please do consult the dermatologist and get your beauty treatment done, or use mechanical methods to get rid of it. That would do wonders for their self-immunity boosting and self-image boosting for them.
Perfect. So very well sum up, I think, Dr. Rakhi, and definitely I'm sure the panelists have been benefited by her opinion. And I would just say that, cyproterone acetate, how does it act? It first decreases the ovarian synthesis. It also blocks the intracellular androgen receptors, and it also improves the hepatic clearance. So, the synthesis is less, the effect is less, and clearance is more. That is how at all levels the cyproterone acetate acts, and that is how it is very advantageous if you really want to have the benefit in cases of hyperandrogenism. So, Dr. Nanda, coming back to you once again, how do you correlate this hyperandrogenism with insulin resistance?
Insulin resistance is almost always seen in PCOS, we can say. And so because of insulin is found in hypothalamus, that is, it is found in brain, it is seen, but still it is a mystery, like how the insulin is present in the brain and whether there are glucose sensors or not. So there is alteration in the HPO axis, wherein you see there is increased release of LH, which is responsible for secretion of the androgens from the ovary. The FSH helps in secreting the estrogens, and the LH is responsible for secretion of the androgens from the ovary. And so this, as in the PCOS, the androgens are more because of LH is high in these patients. Therefore, there is hyperandrogenism. And also insulin is responsible for formation of release of sex hormone SHBG binding globulin. And so as this is decreased, the free androgens are seen in the circulation. So it is a vicious cycle, like insulin resistance leads to hyperandrogenism, and hyperandrogenism leads to insulin. And also there is actually the receptors are good, but it is at the other end, wherein the phosphorylation of the tyrosine and serine is disturbed, and so the glucose does not enter the cells, that is muscle cells. So this will lead to increase in the glucose in the circulation, and so increase insulinemia. That is increased secretion of insulin from the pancreas.
Yes, it is part and parcel of the spectrum. That is what we can say. Obesity, insulin resistance, and PCOS goes hand in hand. Whenever you have insulin resistance, the insulin levels build up and there is hyperinsulinemia. Because of this, the liver produces more and more of the liver produces less of SHBG, so the androgen activity which is manifested peripherally becomes more. Whenever you have hyperinsulinemia, the liver, the insulin-like growth factor binding protein also decreases. So you have more of insulin free, and this in total builds up, and then that gives you, hyperinsulinemia once again. Because of this, there is more and more of LH, and that leads to the ovary theca cell hyperplasia, annulation, and hyperandrogenism. So all of you are well versed with these images of so what insulin sensitizers, I think we have already discussed this, so we will skip this. Metformin, inositol, and N-acetylcysteine. This is also a very good insulin sensitizer, though it is primarily a powerful antioxidant. It has, activity on the insulin secretion in the pancreatic cell. It has also anti-apoptotic effect, and it preserves the vascular integrity and is a immunomodulator. Studies show that it is inconsistent result about its efficacy, though majority of us, I'm sure, we are using it as the sensitizers as well. So should we screen all the adolescents for the metabolic disorders? That is the question, last question from this case. So I think we can have Dr. Mangal talking about this.
Yes.
Should we screen all the adolescents for metabolic syndrome?
Metabolic syndrome is a serious disorder associated with multiple disease states. By screening all adolescents, it will easy to identify at-risk patient, and it will be easy to provide guidance on prevention and management of this disease.
Correct. Just to quote the figures, 5% of these adolescents, they ultimately develop metabolic syndrome. 37% of these adolescents, they have METs, and 63% of obese PCOS adolescents, they develop METs. So definitely hyperandrogenemia, obesity, and PCOS, these are the risk factors in adolescents for metabolic syndrome. So why are we concerned more about this metabolic syndrome? Dr. Bharati, can we have it from you?
Yes, see, this PCOS is a forerunner of all these non-communicable diseases which are on the rise in our country. Not only in the West, we are seeing an increased incidence of gestational diabetes mellitus. We are seeing an increased incidence of hyperlipidemia and hypertriglyceridemia, and the cardiovascular risk is very high. And as in our practice, we are seeing hypertension is on the rise, coronary vascular disease is on the rise, and these are all precursed by this abnormal androgen metabolism and hyperinsulinemia. So we need to tell them that it is not PCOS alone, but PCOS is a part of the metabolic syndrome complex, which can lead to onset, because we are not just the menstrual irregularity and the infertility that we are concerned about. Now we are more concerned about the metabolic disorders this young girl will face in her early reproductive life. Like gestational diabetes is one thing, and that is going to be like a precursor for the unborn fetus also to have an abnormal glucose metabolism, and leading to this increased incidence of diabetes we are seeing. And the atherosclerotic plaques will form quite early in life because of triglyceridemia, and this could lead to early onset of coronary vascular disease.
Correct.
So we need
that is
always
the reason we say that we should catch them young. So adolescent stage, that is the proper time to, if you really want to avoid all these,
talk only about
which lead to NCDs. Yes.
We would talk only about infertility and irregular cycles was what we were addressing earlier. But I think today addressing the non-communicable diseases which are on the rise, endometrial cancers.
Yes,
and
we're coming to that. So we have this case for you now. I think anybody can take up. This is the last case. We have this 42-year-old lady. She's complaining of 42. Mind well that her age is 42. She has come to you with irregular cycles or missing the periods in between, mood changes, thinning of hairs on the head and maybe excess hair on the face and body, weight gain, little depression, mood changes, I said, And this is how she presented to you and came for evaluation. Is it only perimenopausal transition or PCOS, and why we should evaluate it, and how should we evaluate it? I think Dr. Manisha, do we have Dr. Manisha? Dr. Manisha, do we have Dr. Manisha? Otherwise, Dr. Nanda and Riddhi. Dr. Nanda Magai?
Yes, ma'am. Actually, these symptoms which you have given, that is irregular or missed periods, mood changes, excessive hair growth, these can be seen in both the PCOS as well as perimenopausal women. But to differentiate both of them, we have to do the investigations.
Yes.
So we can do LH.
So why are we concerned? That is what we were discussing. Yes.
Because she's more, she can go in for metabolic disorders. So we have to be more careful and take this opportunity and do the investigations and counsel her.
Correct. So she has a 7-fold higher risk of having the atherosclerotic and cardiovascular diseases, and she has a very high risk for type 2 diabetes mellitus if at all she has PCOS or this picture. So definitely hyperandrogenism, excessive weight gain, and the other metabolic disorders. Irregular cycles, we are always saying that perimenopausal AUB, unless proved otherwise, even age-old saying goes that unless proved otherwise, think of malignancy. So we better evaluate her. So how do you proceed for this? Dr. Riddhi, you can take up this.
So in this case, first thing I'd like to see her time to menopause. This patient, I'd like to do an FSH that can at least give me like a sort of an indication how far we are from menopause. These patients, like Madam,
how will that make a difference, Riddhi, for our management? You can just explain.
So Madam, in a way that so it is PCOS, which is a diagnosis, but at least we come to know how far we are from menopause to make sure to tell, or in regards to counseling the patient, is what I feel is that I would like to do that. And of course, these patients, so like we have discussed about all the anti-androgens and all the, so not anti-androgens, the androgens that need to be tested for these patients, all the investigations for for hirsutism, to see her.
I would rather say that whatever her symptoms are, irregular periods, yes, ultrasonography, maybe hysteroscopy guided biopsy, D&C, whatever you want to do, because she's perimenopausal. But she's having all this hyperandrogenism, clinical hyperandrogen. Take a diagnosis of biochemical hyperandrogenism, take a evidence of this, and then of course you go ahead with the management. Is it?
Yes,
I would be more worried if she's a PCOS, because it is associated with metabolic disorders like diabetes mellitus, hypertension, cardiovascular diseases. So we have to evaluate, thinking about that, rule out at least.
Yes. So even if it is a normal transition, you would like to rule out that she doesn't have this. That is exactly what we mean to say, that we have to first rule out all these pathological conditions, then only we have to label this that she is just a case of perimenopausal PCOS. So why are we worried? And she's worried about weight gain. So how does obesity affect PCOS? Do we need to treat it? That we have been discussing since long time, right from the first talk, that yes, definitely more visceral fat, increase insulin resistance, that decreases the SHBG, makes a free androgen more available, and that is how the clinical hyperandrogenism manifests. And it is a vicious cycle, as Dr. Nanda has already talked about. So we are worried more about the metabolic syndrome. So these are the criteria for diagnosis of metabolic syndrome. So I'll just read it for you, that any 3 of the following 5 criteria, that is elevated waist circumference of more than 102 centimeter in men, or more than 88 centimeter in women, elevated triglycerides more than 150 mg% on drug treatment, reduced HDL that is less than 50 mg% in women, elevated blood pressure of more than 130 millimeter of mercury systolic and more than 85 millimeter of mercury diastolic, elevated fasting blood sugar level of more than 100 milligram percent. So measuring waist circumference, how do you do that? You have to do it at the end of the normal expiration. Patient should be in standing position. You ask her to take a deep breath and then you ask her to leave a breath. And at the end of the expiration, you should take the waist circumference. Locate the tip of the right iliac crest, horizontal plane at the level of iliac crest that you have to measure. The tape measure parallel to ground, and tape it should be snugly fit in and not indenting on the skin. It should be just tight. Should not be indenting or may not be loose. That is how, because this waist circumference has got very good, I mean, it is very significant, and that is why you have to use it, you have to measure it properly. So what the message from this case, only message I would say from this case, that just don't think of a normal transition or perimenopausal changes. But before labeling her as normal transition, we have to rule out all these things. Then only as a diagnosis of exclusion, we should label. Suppose she comes it to be as PCOS, then of course we have to advise her whatever dietary modification, active physical exercise, optimizing her BMI. We have to incorporate the cardio and the strength training, muscle weight training, also get enough quality of sleep. I'm sure all of you know that perimenopausal women do not sleep properly. That also adds to her risk. Try hormonal birth control pills if at all you have ruled out any other pathology from the uterus, ovaries, and diabetes if at all she has medication and hormonal therapy. So these are the goals of the therapy. I would just ask Dr.
Add a
Rathi.
point. Can I add a
Yeah. Like, Bharti, yes.
When we come
And
to
then
this
we have a last
diagnosis,
word from Rakhi.
PCOS with overweight and symptoms of a metabolic syndrome, I think we'll have to have a cardiological evaluation and a TMP test, which is very essential because studies have shown that they are, as soon as they attain menopause, they are at a higher risk of cardiovascular disease. And then whether they have any obstructive sleep apnea, we'll have to do a rule out because that is a precursor of coronary vascular disease. And the other thing is whether the fatty liver is a precursor for steatohepatitis, which can also be a problem for this. So these three things in this perimenopausal age, I think we need to evaluate also.
Correct. So I think we conclude by the message from Rakhi. You can, I would just like to congratulate Dr. Rakhi Singh because she has come up with the beautiful posters in her tenure as committee chairperson for endocrinology committee, FOXY. And yes, Dr. Rakhi, can we have the last message from you for the goals of therapy in PCOS spectrum? Do we have Dr. Rakhi here?
Unmute, Dr. Rakhi, please unmute.
Thank you, Sneha ma'am. As it is PCOS, we know that it is a multifaceted disease involving many specialities. It is not one-man army show what we need to do. We need to understand that we have to work in conjunction with the other specialities also in the interest of the patient to a certain extent. Let it be the general practitioner or the gynecologist or the physician or the dermatologist. The mental health is very important to be addressed. The dietitian is one of the most important person to be addressed. The GI specialty general surgeons are to be addressed for the bariatric surgery. Every person is to be involved, and that is for the treatment tailor-made protocol has to be given for the patient. And that is one thing which is very, very, very important. And rightly in the beginning, it was told and has been repeatedly being told in most of the conferences also that adolescent PCOS to a greater extent doesn't occur. And even if it occurs, it could be because of the fetal origin of the adult diseases. Do not label PCOS on the basis of ultrasound. Wait for at least 8 years post-menarche to label the patient as PCOS. Just on the basis of ultrasound, we are not going to label it up. And apart from that, we need to also understand that we need to wait for the HPO axis to be settled for 1 to 3 years. And even if suppose this adolescent child is having lot amount of acanthosis, obesity, and the other symptoms have to be given taken into account. And if she is definitely having, she could be the early stage of PCOS, but not a full blown. But we need to ask the parents and the patient to control on the diet modification, the exercise. And I would tell that these adolescents that they need to do, every adolescent is having a mobile in their hand. They do binge eating. So tell them and inculcate that you have to do walk the talk, which is very important. Because every time they are on the phone, even if they are playing games or something, they are on the phone, on the Google Meet or some Meet or the other. So with their friends, just to chat also. Tell them whenever you are there, do walk the talk.
Yes.
Always do walk the talk. And once that habit comes into it, they will spontaneously, as soon as the call comes, they'll pick it up and they'll start walking. So involuntarily, you're covering those steps and you're doing your homework. And don't sit in front of the idiot box and just hog on it. Play games which are outdoors, which is very important. Rather than sitting inside, if you're asking them, what games are you playing? Yeah, we are playing many games. I play this, I play that. Where are you playing? That is important. But they tell that we are playing on the mobile. That doesn't serve the purpose.
So very well delivered message, Dr. Rakesh.
And one more thing, madam. From the endocrine committee, we have come out with 2 posters on PCOS, that is hirsutism, clinical management algorithm is there, beautifully made. And the other poster is on acne, which is also beautifully made for the management and the treatment part. That can be downloaded and kept in your clinic for the ready recuna. And apart from that, we've also got a poster which is coming, which has come out on hypothyroidism in pregnancy also. These 3 posters are ready recunas for everybody. And GCPR definitely we've come out with on PCOS also for the management and update on PCOS with the Indian studies, not the international studies.
So thank you so much, Dr. Rakhi. I would just, Dr. Rakhi has already summed up, but I would just give the last message as a moderator that PCOS for us clinicians, it should not be the diagnosis from the parents. It should not be the diagnosis from the radiologist, and it should not be the diagnosis from the Google. Of course, irregular cycles, the anovulation or acne hirsutism, and the cystic picture of the ovary. Though it fulfills the criteria, Rotterdam's criteria, this should not be the diagnosis even by you as clinician. You have to understand that the HPO axis takes some time to mature. And of course, these criteria during at least the first 3 years of postmenarchal period, it should not be applied. Ultrasonography should not be done before 8 years of gynecological age, that is 8 years postmenarchal. And yes, optimizing BMI or weight reduction, diet modification, active physical exercise, I would say the healthy way of living, as we have already discussed. Do not use the remotes, do not use the lips, just, do not sit in front of the idiot box, as Dr. Rakhi has said. I would just repeat it once, but all these practical tips, we all have to keep it in mind, and we have to counsel. I as a Foxian, I would say we really need to urge to all of you that give some time for counseling for these young girls who will be guided well, and their life will be, healthy and fruitful because of this fruitful advice. So diet modification, lifestyle changes definitely would go a long way. Of course, active physical exercise, the benefits are so many that not only it reduces the weight, but also improves your glucose metabolism, improves your lipid metabolism, and improves your insulin resistance. That is the best thing to do. That's what I would say. And of course, catch them young. That is the message from my side, that you have to diagnose the young girl if they are having PCOS, because it's not only the irregular cycles, acne, hirsutism, their looks or fertility, but it's the long-term complications we have to think of. And you are the one who can save them from that. So thank you, all the excellent panelists. Thank you, my dear friend, Dr. Rakesh Singh, as an expert. And over to you, MOC. And I once again thank Dr. Monica, who's such a
I would
darling,
like to give a message.
organizing all this program. Thank you so much. Over to you,
Thank you,
Monica.
Sneha. And I would like to give a message. We've coming out with the CMEs on clinical AHA series, which is there, the CMEs have been organized in different cities with the AHA series, that is the algorithm for the hirsutism and acne management. That program is running in the various cities of India, districts, PCOS societies. So if anybody is interested, just let me know so that we can arrange for that.
Sure, Dr. Raki, I'll get in touch with you. Okay.
Sure, ma'am. Thank you for the wonderful initiative. Thank you, Sneha ma'am and Rakhi ma'am, for an excellent moderation. I thank all the panelists, Magai madam, Bharti madam, Riddhi, Mangal Rati madam, Manisha Vasade ma'am, for joining in and sparing your valuable time for this panel discussion with a lot of take-home messages. Pratibha, are you there?
Excellent conduction by Dr. Sneha ma'am, and thanks for the inputs by Rakhi ma'am.
Thank you, my dear.
And thank you on behalf of the panelists for giving us an opportunity.
Thank you so much, madam.
Thank you, ma'am.
Thank you to
Thank you,
everyone.
Monica.
Thank you, Dr. Monica, Sneha ma'am, and Rakhi ma'am. Thank you so much. And just if I can say one last thing, ma'am, since I'm representing the youth brigade here, I think we're forgetting this whole social media. Like such a big, I think now plays a part in the life of every single teenager, right from teenage. I think even before teenage years, they have a phone in hand, and I think screen time and how much and what kind of things they are seeing, and now everything is available to them at fingertips. So I think instant gratification, right from Zomato, Swiggy, ordering food in-house to not even having to go out for anything at all, no physical activity. I think I just wanted to say that yes, social media and also the internet per se, I think we should also as clinicians be very sympathetic towards these young girls and actually just try and explain and take out time to listen to them as well. Thank you.
Thank you.
Very
Thank you,
rightly
Riddhi.
said, Riddhi.
Bharti ma'am, do you want to
I
say
thank
something?
Dr. Monica and Dr. Sneha and Dr. Raki for the excellent panel. I would like to thank the entire AMOG Society and the Public Awareness FOXY Committee for giving me the opportunity. And Dr. Riddhi, your message is very well taken. But I think somewhere down the line, maybe we clinicians don't have the time to spend so much time on social media. But if you just observe wherever you are in the airport or in the dining hall or wherever in a conference, I think they are exposed to this exposure of what all of us are hanging on to our phones, all of us are checking our mails, all of us are checking our WhatsApp, and I think these young children are somewhere following us. So I think we need to set an example, like Dr. Pratik said, that we clinicians have to see that we have at least an optimum weight, do some exercises, have a positive outlook so that they follow us. Otherwise, it becomes very difficult. They'll say, doctor, you are holding on to your phone. When they see us, or their child will say, Mama, you're on the phone, you're on the TV always. Why are you on? This is what, if you have a teenage child at home, you will always get these questions from them. I think we have to lead by example.
Yes, thank you so much, all of you. And thank you for always loving me. Please keep loving me and showering your blessings as always. And yes, I request all of you to support me this year. As you all know that I have already declared my candidature for Vice President FOXY from West Zone. Thank you so much.
Yeah, ma'am, we are all with you.
Thank you so much.
Pratibha, can you give the official vote of thanks now? Riddhi, I had one patient today who told me I have done a lot of research and I've come and I don't want OCPs because I will not get pregnant again. I said, what research are you talking about? She said, okay, I have seen 1, 2, 3, 4, 5, 10 videos, she told me. I said, please
That is
keep the
called
phone
the
outside and then come back to my room.
That is called the idiot syndrome, internet-derived information obstructing treatment. Tell her you have the idiot syndrome.
I have told her that, ma'am. Yes.
Pratibha ma'am.
Pratibha, unmute yourself. Pratibha, unmute yourself.
Unmute.
Okay. I thank Dr. Sneha Bhuya madam, Dr. Rakhi madam for conducting this panel so beautifully and for having inputs from all the panelists. All were very comfortable and it was a good discussion. We have very good take-home messages. Thank you so much, madam. We look forward to meeting you very soon again. The PCO webinar has been very informative. It has given us practical tips on how to lose weight and give practical points to our patients as well. So I thank all the esteemed faculties for today. Thank you, Monica, for making me a part of this webinar. Thank you so much.
Thank you and good night and stay safe.
So much. Thanks.
Thank you so much. Thank you so much.
Bye.
I thank Walter Bushnell and Mr. Sachin Namte, sir, for taking this initiative and being our academic partner. Thank you so much.
Thank you very much, ma'am. Thank you. Thank you, Monica ma'am. Thank you, Pratibha ma'am.
Thank you. Bye-bye, Rakhi.
Ma'am. Ma'am, with our permission, can we close this?
Yes.
Monica ma'am.
Thank you, Walter Bushnell, for the academic grant.
Always
Thank you,
welcome,
Sneha
ma'am.
ma'am. Thank you, Madhe ma'am.
Thank you, Monica.
Can we stop this now?
Yes, we can stop. Pause the group.
Yes. Bye-bye.
Dr. Maz, please close this.
Okay, thank you.
Thank you, Dr. Maz.